Yes, let's call the Laguna Honda Hospital Joint Conference Committee meeting of July 12th, 2022 to order. And I'll ask Secretary Merwitz to call the roll.
Sure. I'll start with you, Commissioner Green.
Here.
And Commissioner Chow.
Present.
I'm going to note that Commissioner Dan Bernal may also be joining us, and possibly Tessie Guillermo. I will read the land acknowledgement before we move on.
Thank you. Absolutely.
San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community, and by affirming their sovereign rights as First Peoples.
Thank you.
Oh,
Thank
sure.
you very much. So now we will ask for an approval of the minutes from the meeting of June 14th. They were fairly short, so are there any additions or corrections to the minutes?
I would move the approval.
I will second it.
All right, and there's folks in the public comment line, so let me go there. Folks on the line, if you'd like to make comment on this item, which is item 2, the minutes of this June 14th meeting, please press *3 now. Again, *3. I see no hands, so commissioners, I will take your motions as action because there's only 2 of you here, and we can move forward.
Do general public comment?
Yes.
Commissioner Green, I'm wondering if we should introduce the people who are on this meeting now, because there seems to be new staff from the Laguna Honda administrative side, and might be good to welcome them.
Well, thank you so much. And actually, I wasn't looking at the grid. I only saw Maggie and you and Mark, and now all these people are popping up. Absolutely. So maybe we can, now I don't know how we go around the room, because I think different people may have different views, but maybe you want to start, Maggie? And
Sure. Good afternoon, Commissioner. That's good to be with you again. Maggie Rykowski, and I am filling in for Roland Pickens this week as CEO.
Amy Fishman.
Hi, I'm Ami Fishman with the Department of Equity and Culture, and I'm going to be introducing Samrit Gruel, who's our speaker for today.
And we have Henry Lifton.
Good afternoon, Commissioners. Deputy City Attorney Henry Lifton from the City Attorney's Office. I'm covering for my colleague Arnolfo Medina this week.
Thank you. And Jennifer Carton-Wade.
Hi, everyone. I've been here before, but it's been a little while. So nice to see you all again.
And congratulations on your appointment.
Oh, thank you very much. Thank you.
And then Lisa, I think we know you, but go ahead.
Hi, thank you, Commissioner Green. It's Lisa Hu, Chief of Staff at Laguna Honda.
And Naz, and this is great for the people here for public comment as well, because they'll know who everyone is. Go ahead.
No problem. Naz Talai, Chief Quality Officer for Laguna Honda Hospital. And you'll have to forgive my voice this evening.
And then Samrit Gridwal.
Hi, everyone. I'm Samrit. I'm an SF Fellow, and I was placed in the Department of Equity and Culture at Laguna Honda.
Great. And now all of you just changed positions, because Chauncey Jackson, congratulations on your appointment, has joined us. Why don't you just say a brief word about who you are and what you're doing? I think you're on mute. I think you're on mute.
He's not on mute, Commissioner, but he may be having an issue. Chauncey, if you would log out and log back in, I think your sound may work again. I'm sorry about that. Sometimes that happens.
Well, in the meantime, I see Terry D'Antoni there. Good to see you, Terry. Oh, she's mute too.
Okay, can you hear me now?
Mm-hmm.
Yeah, Terry D'Antoni. I'm the acting CNO here at Laguna Honda, and I am the actual CNO of San Francisco General. Happy to be here.
Great. And Wilmy Hathaway.
Good evening, everyone. Wilmy Hathaway, Chief Medical Officer of Laguna Honda.
Great. And Zoe Harris is hiding there. I see her screen.
Yeah, good afternoon. My name is Zoe. I'm the Public Information Officer for Laguna Honda.
Thank you. And I guess Mr. Jackson hasn't come back on.
Hopefully he'll pop up. I'll keep an eye out for him. But thank
Okay.
you, Commissioner Chow, for that, and everybody.
Thank you very much. It's great to see everybody now instead of just 4 on the top of the screen.
Thank you. It was good.
So I guess we should go to general public comment maybe.
Yes, folks on the line, if you'd like to make comment about something that's not on the agenda, this is the time to do it. So general public comment is for items that are not listed on the agenda or mentioned in reports. So, and I see one hand. And before we go there, I'm going to read a statement. At this time, members of the public may address the committee on items of interest to the public that are within the subject matter jurisdiction of the committee and commission, but are not on this meeting agenda. Each member of the public may address the committee for up to 3 minutes. The Brown Act forbids a commission from taking action or discussing any item not appearing on the posted agenda, including those raised during public comment. Please note that city policies, along with federal, state, and local law, prohibit discriminatory or harassing conduct against city employees and others during public meetings and will not be tolerated. Moreover, public comment is permitted only on matters within the jurisdiction of the Health Commission. Excuse me. All right, so I see one hand, and I will give every person gets 3 minutes on the clock, and when the buzzer goes off, everybody who's going to make public comment today, please know that your time is up, and I will mute you so you can begin. Person on the line, please let us know that you're there.
Good afternoon. My name is Patrick Manette Shaw. I'll be submitting 150-word written testimony for inclusion in today's meeting minutes. First, I want to alert you that I will be filing a sunshine complaint over the deficient agenda for today's meeting, both in the PDF file of the agenda emailed to me and the online version of it, neither of which mentions anything about Laguna Honda Hospital being brought up during the agenda item number 4. It's not until you dive way deep into the background materials and open the executive team report that there's any mention anywhere alerting the public that Laguna Honda will be discussed today. Second, I'm aware following during your Laguna Honda stakeholder meeting this morning that the city public guardian commented that 2 patients who have been transferred in the LHH closure plan to another skilled nursing facility died after discharge. I don't know if that's transfer trauma, but you have a moral and ethical responsibility to start reporting post-transfer and post-discharge patient outcomes. I recommend that you add it to the Laguna Honda dashboard, reporting progress on the closure and transfer of patients. This is critical information to the public, in addition to the dashboard reporting patient expirations at Laguna Honda Hospital, along with AWOLs and AMA reduction in census. You should be reporting alongside of it quite openly the patient deaths that occur post-transfer. I'm not sure who Erica Spurback is. I assume she's a Laguna Honda employee, and I will be placing records requests with the City Controller, Department of Human Resources, and LHH's public records request to find out what her
Thank you.
working job title is.
I believe we can go on the next item, Commissioner Green. That's the only hand that I saw.
Okay. The next item is the executive team report. And I guess Maggie Rakowski is going to fill in for Mr. Perkins.
Yes, yes. Good afternoon,
Thank you.
Commissioners, and I will present the report along. And my team, the executive team is here today.
We've lost your voice, I think.
There, okay. All righty. Okay, so I'm first going to start with the closure plan. Next slide, Zoe, please. So the plan overview, so the closure plan, closure and patient transfer and relocation plan, it does require that we transfer and discharge all of the Laguna Honda patients because the hospital is no longer certified with Medicare and Medicaid as a provider. Laguna Honda, we are in the process of transferring patients to facilities that can appropriately care for them or discharge them if they no longer require skilled nursing care. We are very committed to continuing to provide excellent care to our patients while they await transfer or discharge, and will ensure that the next best possible place is found. Yesterday, we hosted a Laguna Honda Family Town Hall to provide updates and answer questions. We had very good attendance. There were approximately 90 participants. And one thing that we did that was very well received this time is we had it simultaneously translated in Chinese and Spanish. Next slide, please. So this is just an overview of the closure plan that has been approved by CMS. It's just a schematic of the processes and steps that we are taking. Next slide, please. And again, this is our progress. As you can see, our patient census, our assessments that we are doing, patient assessments, family meetings, and patient referrals. We are actively calling various facilities to find vacant beds, have them identified. We have indicated here our transfers to skilled nursing facilities. Next slide. And here is our discharges to the community. And our discharge placement types from the community that is outlined in the slide. Next slide, please. So for our next steps, we are continuing to follow the transfer and discharge process very, very closely and to continue providing care for patients while they await transfer or discharge. We are diligently working to increase the number of transfers and discharges each week so that we can follow the CMS approved closure patient transfer and relocation plan. Next slide. So this slide is just a visual on our CMS recertification timeline. As you can see, there are many steps, and we are very diligently working to meet this timeline. Next step, next slide, please. So as we prepare for recertification, we are continuing to work very hard to meet all of our regulatory requirements. When something is identified, we are making quick fixes. We are ensuring that we can make improvements. We want to ensure that we are doing everything that we can so that we can have Laguna be on the right path. Our certification experts we have on site that are conducting comprehensive assessments, are giving guidance, and our mentoring staff, and we are really implementing those improvements so that Laguna Honda can be recertified. Next slide, please. Zoe, can you go to the next slide, please? Okay, so our mock surveys. So we completed the first portion of our mock surveys on June 29th. And these surveys replicated the real CMS surveys. They were unannounced, and we had a large team came throughout the hospital on all shifts for several days. On the life safety survey, the surveyors actually arrived yesterday. And so we are now in the process of our life safety survey. They will be here this week and part of next week. We do have a second mock survey that will take place later this summer, again, to test our survey readiness before our CMS recertification surveys. So our mock survey did identify gaps, and we did make immediate improvements, and they're already underway. And we did work with corrective action plans to develop for long-term improvement. We did nursing actually held a plan of correction summit where they actually brought staff together and actively worked on preparing the corrective action plan. And we also are going to be preparing a comprehensive education and training program. Okay. Next slide, please. And as part of our preparation, we also did a pilot, a reorganization, and this took place on July 1st. We launched a pilot reorganization to model high-performing skilled nursing homes and align us with the skilled nursing facility model. One thing to note is that the pilot does not impact job classifications. It refocuses disciplines back to their areas of expertise. And in some cases, staff have the same reporting structure. Next slide, please. And this is, I know this is very difficult to see, but this is actually the pilot reorganization for Laguna Honda. Okay, next slide, please. Okay, so for bed reduction, you may have heard of this. Laguna Honda is required to change policies, procedures, and operations to meet current regulations and allow for successful recertification. One of the requirements is that we can have no more than 2 patients per room. We currently now have some rooms that have 3 patients. So we must reduce all rooms with the 3 patients to no more than 2 per room. This is a reduction of 120 beds with the new license, skilled nursing bed count being 649. So that's a reduction from 769. Our 11 acute care beds are not impacted. We do have a task force that is working with the resident care teams to identify and move patients in a way that minimizes disruption and supports patients and the units. Okay, next slide, please. Another project that we have underway is the kitchen floor renovation project. And this will help modernize the kitchen floor and bring it up to current regulatory standards. And this is also something that is required for recertification. We did submit a documentation to CDPH in preparation for the project, and we have done some pilots on several neighborhoods. We are working to ensure that, all of our meals are very nutritious and safe for all patients when the production kitchen is closed. The galleys on the neighborhoods will be used for on-unit meal preparation. And we do have ongoing consultation with CDPH. And recent consult did result in the need to identify an alternative food service vendor. And we are in the process of doing that. So our timeline on this project is yet to be determined. Next slide, please. Okay, and some additional milestones. We are really focusing on education. We completed online learning modules. We have, to increase communication, have initiated daily change of shift huddles to communicate critical CMS recertification and patient safety information. And we have completed the preliminary placement assessments of all our Laguna Honda patients and initiated a process in collaboration with our Laguna Honda Ombudsman of identifying patients who are appropriate for discharge into community-based care. Next slide, please. We have also made some other additional improvements with our nurse executive team, providing a gap analysis to ensure that we have our plans of correction are in place, and we have assessments being done so that we can ensure compliance across all rules and regulations by each unit and across each shift. And also looking at our CMS critical pathways and standardized procedures and making real-time corrections and improvements. Next slide, please. So on safety, this is just a quick visual of our COVID-19 cases at Laguna Honda. And even though we are in a surge in the Bay Area, we're still holding pretty well with our Laguna Honda, with the COVID cases. Next slide, please. And this is just a visual of the hospital admissions and discharge and expirations. New admissions are currently on hold due to the closure plan. And as you can see, as our planned discharges, that is actually increased. Next slide, please. And just some additional updates. Our care experience staff, they did host a food truck for Staff Appreciation Day. And this was very, very well received. Staff were extremely grateful and very appreciative. And this was for all 3 shifts. And the team is actually looking at developing other events of activities to foster, really a culture and increase staff and patient engagement. And this event went over very, very well. Next slide, please. And then we also, Laguna Honda patients and staff did join the DPH Pride Parade contingent. And that, I know that people really enjoyed that activity. And then we will be hosting the annual Pride Prom in Gerald Simon Theater in July. And this is an annual event. And so we're looking very forward to that. And with that, that ends my comments, and be happy to take any questions that you may have. And for that, myself or the team can answer for you.
Well, thank you so much for that presentation. And I see President Bernal has joined us. Thank you so much for being here, President Bernal. I can't see everybody, so I don't know if Tessie's come along or not, but is there any public comment on this item?
Yes, Commissioner Guillermo is there.
Okay.
And Zoe, also please stop sharing your screen so that we just get the faces of who's talking. And folks on the line, if you'd like to make public comment about this item, please press *3. Again, *3, and I will recognize you with 3 minutes. I'll read a statement. For each agenda item, members of the public will have an opportunity to make comment for up to 3 minutes. The public comment process is designed to invite input and feedback from individuals in the community. However, the process does not allow questions to be answered in the meeting or from members of the public to engage in back and forth conversation with the commissioners. The commissioners do consider comments from members of the public when discussing an item and making requests to the DPH. All right. Excuse my cough. I see one hand. Oh, I see 2 hands. Okay, great. And again, I will unmute you. Please let me know that you're there, caller.
Yes, it's Patrick Monette Shaw again. Shame, shame, shame on this JCC, Grant Colfax, Michael Phillips, and the entire Laguna Honda staff. You all must know that those 120 beds being removed because you have to apply for recertification would not have been required had you passed the March 8th survey. That you continue to have violations of CMS FTAGs, which you've been dealing with for, 20, 30, 40 years, which you should know all 200 of the FTAGs. You would not have been removed from CMS provider participation. In my humble opinion, and I'm going to publicize this, the failure and the decertification represents either nonfeasance or malfeasance. Shame, shame, shame on all of you. On another matter, I got a next request, a response today about the number of PT and OT referrals that are automatically routed into the EPIC system. The response today said there are no responsive records. So in addition to the HMA preliminary assessment findings that reported that HMA staff are having trouble accessing the EPIC system to check, oh yeah, care plans, which is bizarre. Now it turns out that you cannot glean from EPIC either the number of out-of-county discharges, which is bizarre because of discharge planning modules in EPIC, but now I'm being told there are no responsive records about the number of PT and OT referrals. And I remind all of you, I am asking for aggregate, de-identified numbers of referrals. I'm not asking for HIPAA information, HIPAA protected information. So I have to wonder, what is that damn $164 million EPIC database incapable of that I haven't figured out yet what else it's not capable of? Shame, shame, shame on Department of Public Health, Grant Colfax.
Your time is up. Thank you, Mr. Monette-Shaw. Always pleasant to hear from you. All right. Dr. Palmer, are you there? Dr. Palmer? I have unmuted you, but I don't hear you. Let's see, let me try again. Dr. Palmer, are you there? Commissioners, how about if we, if you all do discussions and I'll try to problem solve with Dr. Palmer. I have her number. I can call her and see if there's something I can do. So how about if you continue your discussions amongst yourselves? I obviously will be taking notes, and we'll go from there.
Thank you, Mark, and thank you, Dr. Green, for assuming the chair in my absence. That's something that unfortunately couldn't be helped. So yes, are there any comments from commissioners or committee members on this item?
Yes, welcome back.
Thank you.
Dr. Hermel. I had wanted to make several questions. Well, I wanted to ask several questions in regards to the executive report, which here at Laguna includes the finance and gift report, and as part of the report, which sometimes we kind of forget about, or even the vacancy report. So I just have some questions on each of those. And first, I would say that the closure plan data is quite extensive, obviously very complicated, and so thank you very much for allowing us to continue to track with you this very complex process and challenging process, should we say. My first question really was related to the fact that if we are reducing the number of beds available, it was my understanding, and you could probably correct me if it isn't true, that because our current bed count is low, it doesn't actually dislocate anybody because of that. Is that correct?
Sorry, when you say dislocate, you mean the...
Well, in other words, if we're going to reduce, would somebody have to be moved because we have run out of beds from our regular census?
No, no. At this time, the patients, they're being relocated to other rooms within the facility.
Ah, okay. That's what I was concerned about. Yes.
Yeah.
I know you have to get down to 2. Okay.
Right. So that what they're doing is they're identifying who needs to be moved, and then they're working to actually move that patient, but it's in Laguna Honda, in the facility. They're not being moved out of Laguna Honda due to this bed reduction.
Okay, great. I think that's important for the public to understand that people aren't being moved related to this particular.
Correct, that's correct.
Of course, it's a shame that we are losing beds, but more than a shame. I was wondering, the kitchen project does sound like it's been going on for quite a while. So if I recall, it actually was going to begin sometime before or maybe around the beginning of the year, in fact. But I was curious as to its delay at this point, how it took so long to actually get to where we are, and also what was the need for alternative food survey vendor? Did they mean they didn't like the survey vendor, or that you have to have a backup in case that particular selected vendor did not perform, or what was the consultative recommendation?
Yeah, Commissioner Chow, I believe it was that there needs to be an adequate variety of choices for the patients. And so we'll be working with another vendor who can provide an adequate variety, and the meal plans have to be for several weeks. And the vendor that we had currently selected only had a very, did not meet the weeks, the number of weeks that the meal menus were available.
Sure. So what is your timeline then for the kitchen renovation, which is sort of separate really from the whole certification issue?
That is correct. And Chauncey, I'm not sure if Chauncey Jackson, if you have any information on that. I know that they are very diligently working on this. They're diligently working to find another vendor. But for the timeline at this point, I do not know, and I don't know if any of the other exec staff members might know timeline.
Ms. Rakowski, Chauncey's in the meeting, but I can't move him over, so I've unmuted him, and he can speak. Chauncey, are you there?
Can you hear me, Mark?
Yes, go ahead, please. If you have information to respond to that question, please do.
No, I do. We do not have I do not have any knowledge of a timeline yet. I just know they're working on one, but I can always bring that back to the team.
Yes.
No, that'd be fine. I think that's what I was going to suggest.
Yeah. So Dr. Chow, we will get that information to you.
Sure. No, it's fine as long as we get an update as we go along. It's just that it's been a project that's pending for if I remember, quite a while. So on the number of you noted under the recertification that you were appointing additional PhD trained nursing executives. Are these the same people that we're talking about in terms of your pilot reorganization, or are there additional staff that will be working with the nursing staff?
This is an additional staff. It's one additional nurse executive who is working with the nursing staff.
I see. And it's one, and so it's a separate function, not part of this pilot of separation.
Correct.
To the towers. Okay.
Correct.
No, thank you.
And providing excellent nursing expertise.
Okay, very good. Certainly the COVID cases look like in July there's been a dramatic change, including within our staff, which hopefully is a trend that we will see through the rest of the city. My other questions relate to actually the other parts of the report. On the finance report, I wanted to get a clarification as to the revised budget numbers, and it's just a definition. Is this the revised budget after the mayor's and board of supervisors acceptance, or is this a revised budget after the CMS survey?
I believe Lily Conover was going to join the meeting so that she could answer. She's our.
Yeah, I'm here.
Lily, are you on?
Yeah, I'm here. Can you hear me?
Excellent, excellent. If you could answer, excellent. If you
Sure.
could answer that question for Commissioner Chow.
Yeah, it's not related to the recertification process. The mayor's office approves the budget annually, and then if we have adjustments that need to be made after the budget is made public, then that's what goes into that revised budget column.
Okay, so that is our traditional definition,
Yeah.
like we have throughout the rest of the department, right?
Yep.
That's very good. On the gift fund report, and I thank you for your response.
Yeah.
I think that the issue more is if it is clear, and perhaps it just needs to be a separate line that indicates that donations that are given and therefore the use of that, maybe just a separate double line so that we don't get back into the public that complained that donations were, quote, meant for the residents, whereas if
Yeah.
there are donations on this side, I don't see a reason personally of having a separate report. I just think that gift funds can have separate parts, but I would leave that to administration. That was my only question, just to bring up that in the past, this has been a controversial subject when it was used also for patient benefit, but actually because of staff enhancement. And so I think we want to make clear that we are following this. That's one reason we have this report before us, to be sure that the expenditures are appropriate. I mean, it became sort of a big public issue, so.
Yeah, and actually, I appreciate that you had the question because we haven't received any employee recognition donations for quite some time. And the city and the controller's office recently started allowing departments to receive donations for staff and employees. So we've been kind of working through how to report these out. And so far, we've only gotten this one $9,500 donation. So it makes absolute sense to remove it in the way that it's listed on the report now. And I think we need to think through as we get more donations, if we do, what the best way is for us to report these out. But we are very aware of the issues that happened in the past, and where everything is separated from an accounting perspective. I agree that it looks a little funny the way that it's lumped in here on this report.
Yeah, so I think just separating it doesn't mean you need a total separate system, but
yeah,
and that way, so as long as the public understands there is then a staff fund essentially, then that would be helpful, because this kind of the general term kind of is a little misleading, but from the perspective of the assumption that it was all for residents. So, thank you.
Right. Sure.
So I appreciate your answers in the past, and we'll look forward to getting a timeline and hope for the kitchen ultimately. Thank you.
Is any additional questions, Dr. Chow?
No. I am sorry that I didn't have a chance to write these out. So,
Dr. Green.
First of all, thank you for the responses you wrote down to the questions I had. I really appreciate them. And I guess, this closure plan progress report is really excellent, and it gives us such a great snapshot of what is going on. I guess the part that of course is most alarming here is to see the number of beds available in the state and the number of beds that will accept our patients, and the idea that organizations that are scrutinizing us, like CMS, are apparently not engaging in any way to try to help us help facilitate expansion of the bed numbers. So and then thank you also for elaborating on, as part of this patient assessment, knowing that in fact there are about 600 who would need a skilled nursing facility is extremely helpful, because it's a little more than I anticipated, meaning that it's even more critical that these beds seem not to be available. So I guess I'm curious to know about the communication you have gotten from any organizations, leaders that might be empowered to help us in this process, so that, residents are not, heaven forbid, sent to another state, another galaxy. I mean, I'm just wondering here, what the what the feedback has been, and what how with all of the work going on, presumably this will never come to pass. But I'm just wondering if what you've heard, or what kind of feedback you've had on this conundrum, because you're clearly sharing this information. It's nothing in your control.
Right, right. Well, we are in close communication with CDPH and DHCS. And I know that we meet with them regularly to talk about our numbers and bed availability. And I know that DHCS did send a letter to skilled nursing facilities, I believe in the state, letting them know that we have this need and trying to find out what is their vacancy, what bed availability do they have, and then that if we do contact them and there's a match, because again, we want to make sure that if we do transfer and discharge and transfer any of our residents, that is to an appropriate facility. It needs to be appropriate, and that they'll get the appropriate level of care. And so that we do have that engagement with them, that they have reached out and said, please, if you're contacted by Laguna Honda, if you do have availability and there's an appropriate bed available, that they should really work with us.
Thank you. And I guess the other question, in terms of some of these assessments, and I suspect you've done this, but are you able to project potential length of stay that some of our residents might require should they need transfer? In other words, if some would need 3 months and others would need more permanent placement, does that in any way aid you in helping to find beds, or maybe even make beds open if, for example, a facility knows that there would be a short-term rather than an extremely long-term need?
Yeah, Commissioner Green, I'm going to see if Dr. Hathaway could answer that question for you.
Sure. Hi, Maggie. Hello, Dr. Green. So our patient assessment is not that detailed. Overall, our patients are long-term care. They require long-term care. They need long-term care housing. The individuals that are short-term care, we are not, because of the level of care, they will be grouped into the lower level discharge, such as a boarding care or home, if possible. But for the folks that are SNF level of care, there will be SNF level of care, and that is the trajectory, that is the plan. And that's some of the barriers that we are faced with when we call these facilities and ask for beds. Some of the reasons why our patients are not being accepted or being denied is because they don't have long-term care beds available for our patients.
So the 60 that you say can, be discharged to board and care, those are basically the ones that are short-term patients, and they're really everyone else. All the 600 then are individuals with indefinite need.
That is correct.
Great. Thank you for clarifying that. I really appreciate it. Thanks so much.
Okay, and I just wanted to make a sort of an addendum to Dr. Hathaway's comment about the long-term care, just anecdotally from facilities that I'm familiar with. It really is that issue of both appropriate level of care and available long-term beds. And I think a lot of the administrators from some of these other facilities are also now worried about CMS coming down on them in the way that they've come down on Laguna Honda. And so there's a lot of caution. And so without help from CMS or other, other regulatory agencies to help us place, I just don't see a lot of hope, particularly in the Bay Area, maybe even in the state. So, it is not for lack of trying, absolutely. Okay, if there are no other comments, Mark, did we get Dr. Palmer back in?
She's called in, so if we can go to her.
Yeah.
Dr. Palmer, is that you?
Hi. Yeah, I'm very concerned about this, especially since I learned in the last in the stakeholder conference that 2 of the public guardian patients died within days of being transferred. And we know that the literature shows that in nursing home patients, transfer trauma or relocation stress, which is the current terminology, is extreme and results in a high mortality rate. There's a very high mortality rate. And so I'm confused. Does CMS require that the facility be completely emptied? And is there a way of holding back on transferring the patients who are the most medically complex and the most at risk from death? And how can I, as a San Franciscan, as a concerned person, influence CMS? The public guardian herself said she's holding back. She wants to hold back on discharges. If there is a good faith effort to recertify, recertification is likely. Is CMS requiring us to kill people? That's my question.
Just to remind everyone, thank you, Dr. Palmer. Just my statement earlier said that questions from public comment are not answered in the meeting. Commissioners, you can choose to re-ask that question or ask for information later on, but that's not how public comment works, where someone asks a question and there's an answer. But commissioners, it's up to you around how to engage with that.
Thank you, Dr. Palmer, for your question and comments, and thanks, Mark, for that clarification.
Right. I think with the clarification, Chair, it would be useful for the public to hear what types of constraints we are under in terms of not making a good faith effort as required, recognizing that certainly the literature shows that these transfers are very traumatic for people. But as I understand it, we're really under obligation to do so. So maybe we can get clarification and let the public see that it isn't something that we want to do, but something that we are required to do.
Thank you for asking Commissioner Chow. Is there a response to Commissioner Chow's question that is answerable? Maybe I can turn to you, Maggie, for a response.
Yes, we can get that information to you.
Okay. All right, Mark, I guess we can move on to the next item. Is that the regulatory report, or are you calling items? Okay.
Yeah, sure. Item 5 is your regulatory affairs report.
Okay.
Good evening, Commissioners. I apologize, Geraldine Mariano had an emergency, so she cannot be with us for this presentation, but I will present on her behalf if you will allow me. And for the public, again, I'm Nazanin Talai, the Chief Quality Officer for Laguna Honda Hospital. I'm sharing with you today the Regulatory Affairs Report, which reflects the months of May and June, as we did not have the opportunity to share this last month. Overall, for the past 2 months, the facility had 35 facility reported incidences that were reported to CDPH and 3 anonymous complaints that were shared to the facility by CDPH. The month of May had 14 reported incidences, while the month of June had 24 incidences. And you can see the breakdown there within the report. So if you wouldn't mind scrolling down, please. Excuse me. Thank you. There have been no survey updates or plan of correction updates at this time. We do continue to have site visits by CDPH. They are still coming on site to the facility to review and close out outstanding facility reported incidences. For the month of June, we hosted them on site on 3 different dates. For 2 of the dates, they were reviewing similar cases as they didn't get to finish. So on June 2nd, when 3 surveyors came on site, they were reviewing 23 facility reported incidences and 3 anonymous complaints. They returned back on June 15th to continue their case review. and then again on June 22nd. We've not received any official letters from them at this time, and we still do have over 200 incidences that are pending site visits and review. And then, of course, the graphical breakdown for you in regards to the type of incidences and the incidences that are pending and or investigations not started. Happy to take any questions or comments.
Thank you, Naz. Are there any public comments on this item?
Folks on the line, if you'd like to make comment on item 5, the Regulatory Affairs Report, please press *3. I believe there's a hand. Okay. Caller, please let us know that you're there.
I am. This is Patrick Manette Shaw again. You pretend that you're working towards recertification, but this Regulatory Affairs Report reports 35 facility reported incidents in apparently May and June alone, 9 of which are staff to resident abuse cases. 24 of them are allegations of abuse in total. That level of abuse of the 35 FRIs reported in just 2 months is not going to help you with recertification. You folks need to get your act together. And I might just add that for any CMS or CDPH regulators listening in on this meeting today, I think they're going to be pretty appalled by Commissioner Chow's hubris in claiming that the 120-bed elimination is not really that bad because it doesn't displace any current patients. What Dr. Chow, who has served 30 years too long on the Health Commission, fails to understand is that those 120 beds serve hundreds of patients a year. And that by eliminating those 120 beds, it is more certain that patients who need those beds for long-term care are going to be dumped out of county, separate from the discharge and relocation plan, because 120 beds are not going to exist in the city, exacerbating the already dire shortage of skilled nursing beds in the city that have been declining for years and years and years, which I think Dr. Chow knows all too well. So, Dr. Chow, I suggest you check your hubris at the door before you attend any more meetings of this body or the full Health Commission. It's appalling that you say, oh, it's not so bad that current patients won't have those beds. You're absolutely ignoring that future patients that need those beds can't access them.
Thank you for your comments. That's the only hand I saw raised, Commissioner.
Thank you, Mark. Are there any comments by the members of the committee? Okay, I know that Commissioner Green had some questions about the Regulatory Affairs Report that were answered in the email. So unless there are any additional questions, we can move on to the next item, Mark.
Sure. The next item is LGBTQ resident experience at Laguna Honda Hospital. And Ami, I'm going to give you permission to share screen.
Actually, I believe Samrit's going to share screen. I'll just take a minute while she's pulling that up to give a quick little introduction, if that's okay.
Of course.
Great. So so I wanted to formally introduce Samrit Gruwal. Samrit's been working with us in the Department of Equity and Culture since last October as a San Francisco Fellow. Her fellowship is coming to a close this month, and we just wanted to really publicly acknowledge and appreciate Samrit for everything that she's brought to Laguna Honda, and especially for being so engaged and involved during this really challenging time for us all. She's been a wonderful addition to our team and has moved a lot of our work forward, including the work that she's going to present to you today about assessing the needs of our LGBTQ+ residents. So Samrit will share her presentation and then pass it over to Jennifer Carton-Waite, who's going to talk a little bit about our next steps and how this work connects to our recertification efforts. And then we'll all be available for any questions that you might have. Go ahead, Samrit.
Thank you, Ami. So I'm unable to share because I would have to quit and re-enter. So Ami, unless, do you have it pulled up? Or I can
I can pull it up, but I don't have permission to share either.
I need to give that. It's only one person at a time. So Ami, I just gave you permission. It takes about 5 seconds to show up.
Perfect.
Bottom of the screen to say the share button should show up.
Okay, let me.
Sorry about that. Thank you.
No problem. Okay, one moment here.
There we go. It's showing, Ami.
Okay, great. Let me just see if I can put it into full screen here. Okay, is that working?
Yes.
Okay.
Okay, thank you. Hi, everyone. So welcome. This is a presentation on the LGBTQ+ resident experience at Laguna Honda Hospital. Next slide. For the agenda today, I'm going to start with an introduction and then go into the data collection process and method of how everything was collected, the findings of our research, and the conclusion, and ending with conclusion and recommendations. To introduce myself, my name is Samrit Gurwal. I'm a San Francisco Fellow of the cohort 2022, and I was placed in Department of Equity and Culture at Laguna Honda. I graduated from Berkeley in 2021, and I'm from Fresno, California. And I did this, this research project was actually began by a fellow from cohort of 2020, Jam Chen, and they graduated from Stanford in 2019. Starting with our introduction, next slide. So what is this project? This project was initiated in 2020 by Jam Chen with the emphasis on sexual orientation and gender identity data at Laguna Honda. It was to assess and better understand the care and needs of LGBTQ+ identifying residents at Laguna Honda. So JAM created this A3 back in 2020 before the pandemic, and they had began to collect resident interviews and also began to collect resident SOGI data. So I have picked up from then on, but this is the A3 that they began with. So why this project? In 2020, 1 in 3 LGBTQ+ identifying peoples have faced discrimination of some kind in the United States. And San Francisco has one of the largest and most prominent LGBTQ+ communities in the United States, making it a safe haven for LGBTQ+ community here. And Laguna Honda Hospital is the only dedicated skilled nursing facility for HIV and AIDS in the San Francisco Bay Area. And HIV and AIDS disproportionately affects the LGBTQ+ identifying community. And at Laguna Honda, we follow the true north to help shape our improvement work and efforts for continuous improvement in all functional areas. And of course, this is our true north, and equity is one of the 6 pillars. And these 6 pillars exist to provide the high quality of care that we want to achieve and for continuous improvement. Next slide. So I wanted to introduce, not introduce, but this has been existing LGBTQ+ Bill of Rights in long-term care facilities.
Sorry.
No worries. The LGBTQ+ Bill of Rights in long-term care facilities, which began with an ordinance passed by the Board of Supervisors and signed by the mayor to assure that residents in long-term care facilities have all the rights below without regard to a person's actual or perceived sexual orientation, gender identity, gender expression, or HIV status. And these Bill of Rights are supposed to be shared with all residents and upheld by all staff. I wanted to share 2 of the rights just to get a gist of what it is. But one, residents A resident's admission to a facility cannot be based on a person's actual or perceived sexual orientation, gender identity, gender expression, or HIV status. A resident will not be involuntarily discharged based on the above. And number 3, where rooms are assigned by gender and individuals' request based on their gender identity will be honored. And there's also a booklet that the San Francisco Department of Aging and Adult Services created to explain all of these rights. So to give just an overview of the state of the LGBTQ community in 2020, a national public opinion study was done by the Center for American Progress in conjunction with the research group from UC Chicago. And overwhelmingly, there's been...
Sorry.
Nice. There's been LGBTQ plus identifying patients in the U.S. who face difficulties in 2020 accessing necessary medical care due to cost issues, discrimination, being afraid of discrimination, which would make them avoid medical treatment and such, and also just felt uncomfortable going to a provider. Next slide. And then zoning in on San Francisco, the Human Rights Commission did a study in 2014, and that's actually the most recent study. So done by the Human Rights Commission on the LGBT aging at the Golden Gate, so in San Francisco. And again, overwhelmingly, San Francisco seniors felt it would be unsafe for LGBTQ plus seniors to be out in facilities. They believed that staff would discriminate against an LGBTQ plus person, and other residents would, and also felt that they would be neglected or abused by being out or in the community or in hospitals. Next slide. So now heading into data collection, what we did to collect this data. So recruitment, we began by creating posters and working in conjunction with activity therapists and social workers to recruit LGBTQ plus identifying residents at Laguna Honda to participate in an interview. And then we interviewed a total of 10 residents with questions like, do you remember filling out SOGI data during admission? How did you feel? Also, how do you feel with staff and more questions? And we also interviewed 3 physicians on South 2, which is the HIV and AIDS specific floor or unit. And I also interviewed ombudsmen to get a different perspective outside of staff and residents, and then also collected hard SOGI data, extracted that data from Epic and analyzed that as well. Next, so going into our findings. So this is a hard to explain graph, so I'll go really brief into it. But the first line is the total admits at Laguna Honda from January 2021 to March 2022, and the second line is those who have filled out the sexual orientation, gender identity part of in admissions. And so you can see that there's a pretty big gap in that, and not everyone fills out that data. And going into the next slide, we have a pie chart that kind of helps explain that. Around almost 65% of admissions from January 2021 to March 2022 filled out sexual orientation and gender identity, while 12.8% left that incomplete, and 18.9% also, they filled out only gender identity, not sexual orientation, and those who only filled out sexual orientation were 3.4%. So if one or the other, gender identity is, again, something that residents are more comfortable filling out, but also our goal is to make to get this circle to fill to be 100% SOGI complete. Next slide. One huge theme that I saw in the interviews was community engagement and how important that is for our residents, especially for LGBTQ plus identifying residents. Next slide. So I wanted to start off by this quote from one of the interviews, which was Laguna Honda Hospital is in Nirvana. And this stuck out to me because I've been here for 9 months and my fellowship ends at the end of this month. And I truly have seen that myself, that Laguna Honda Hospital is in Nirvana. People and residents learn about themselves, even staff learn about themselves. And it's not a typical long-term care facility. I think, again, everyone gets to learn about themselves. So this really stuck out to me. Next. A need for creative space. Creative spaces is one huge theme across the interviews. Art with elders was noted as the best part of Laguna Honda Hospital. Residents have said, allows me to connect with creatives and felt that creative fields are gay-centric in general. They've made friends through music and also sing in the pain clinic. And so creative spaces were a huge theme across most interviews. Feeling alone and a need for more social spaces. So these are four things that came up by residents. That what they wanted and how they felt, but social groups and not support groups. Residents wanted opportunities where they can meet and socialize with one another without any specific labels. So not a specific LGBTQ plus support group, but just a social group so they could meet one another and build that community. Also, they felt that there was no LGBTQ plus culture outside of Pride or the AIDS Walk. And so they expressed the need for that as well. That they don't know each other. And residents feel that if there is no community, which is why they don't know each other. And then collaboration comes from that, where residents express that they don't know many people outside of their unit. So they want more outside activities to meet other residents so like cross-unit collaboration kind of. Next. Comfort around others. So many residents who identify as LGBTQ plus felt comfortable around those who also identified under the LGBTQ plus umbrella. And their interactions and friendships were primarily and overwhelmingly with those who identify the same as the resident. And they also felt that it was hard to express themselves to those who don't identify as LGBTQ plus. So LGBTQ plus residents and LGBTQ plus staff and the relationship between them, residents felt the most comfortable around staff who also identify as LGBTQ plus. They felt seen, accepted, have better care, and comfortable. However, there have been negative experiences with staff also, and these were two quotes, kind of the same, but different reactions. But one one resident had said, "Grown old woman being funny by calling me girl, we're not all the same. Staff doesn't know me well to call me that." And another resident said, "Call me girl, but I'm okay with it." So we see that some of our staff are assuming based on sexual orientation or perceived sexual orientation, calling again names or misgendering even. So that's another takeaway from this project. And so like to strengthen that relationship between staff and residents, residents longed for a stronger foundation. So they expressed that there was great inconsistency where nursing staff is changing shifts, and so they don't get to see the same people consistently, and how many rounds physicians make, not being able to see them consistently, and also being personable, asking about, they wanted staff to ask about their personal life, some because at the end of the day, this is their home, and they want that connection here. And so one example was there was an abuse case, and the resident said that nobody asked them how they were after that, rather handed them the paperwork. And so again, just making that personable connection was what is needed according to many residents. So other perspectives. So I also had conversations with physicians on South 2 specifically, and when asked about barriers to healthcare, the number one barrier to control HIV specifically was psychosocial care. They expressed the need for more psychosocial cares with psychiatry, therapy, and whatnot to help the residents on South 2 specifically, who disproportionately again identify as LGBTQ+. And in the conversation with Ombudsman, Ombudsman had stated that staff should be more sensitive, create LGBTQ+ anonymous, so sort of a support group because we don't have that support group, and have a monthly sexual orientation, gender identity report given out to staff every month, and also review the LGBTQ+ education training. So recommendations. Started out with I start off by naming the most feasible I am saying, and then ending with the kind of the harder one. But to create more social spaces with art, music, and again social groups, not support groups, for that collaboration across units. And update training materials. We don't want our residents to just feel comfortable with the one with those who identify as the same as them. We want them to feel comfortable and feel respected by every one of them. So review our current training materials and focus and build focus groups with residents and staff to better train our staff, and also have interactive training where there's role play or practice in situations. And then third, increasing our SOGI data admissions. So talking with admissions and eligibility staff and auditing our data, and also identifying the barriers and getting that number to 100% so everybody fills it up, and preventing those barriers from preventing there to be a decrease in numbers. And then lastly, create an LGBTQ+ identifying unit. I think this could start out with a pilot program in a neighborhood. We can try. We could put one neighborhood as an LGBTQ+ identifying neighborhood, and see and assess that for the feasibility and the barriers that come with it. But yeah, those are the recommendations. And now I will pass it on to my colleague Jennifer Carton-Wade for the next few slides.
Good evening, everyone. Nice to see you again here. And I wanted to give context for how we can use this information moving forward. So we have, as a part of recertification, we have started a care experience team. And what we're doing is collecting all this information from residents and staff and other stakeholders, families, community, as a means to transform Laguna Honda into a healing organization that really centers around equity and trauma-informed systems. It's really about belonging. So what you've heard Sumri talk about tonight is some people feeling like that they do belong and they found their place, and some people needing a little more. And we can do better, for sure. We can do better with how we work with our LGBTQ+ residents and staff for that matter. So what Care Experience does is that it focuses on all these different voices and takes them and elevates them. So as we're making different decisions and moving forward in recertification specifically right now, but it should be all the time. I would like to say that, the Equity and Culture Department, newly established, but this has been the goal of it the whole time. Because we recognize that people, when you see them, they show up, right? And what does that mean for a resident? That means that I'm genuinely myself and able to see the resident as their genuine selves, and that comes across, or that doesn't come across, but it creates excellent care if everybody's comfortable in their space. And so that's really the goal of the Care Experience team as we move through this process. And we're gonna, next slide, Tommy, please. So we're gonna review these findings with leadership other key stakeholders. We will take a look, the idea of an LGBTQ+ maybe household in a neighborhood. That's something that we could potentially pilot as we move through the recertification process. Again, it will take a lot of planning, but it's something that we could definitely raise as something to try. We will also be creating a plan to implement some of these other social spaces closely with the activity therapy department. And then we will continue this engagement with our residents to make sure that we'll follow up with some of these same questions as we move forward. How are we doing? Did we change? How did we change? What did we do in order to make that change? And, this is a really special project, and I want to thank Sumrit, and I want to thank Jam for kicking it off, and Sumrit for really finishing strong. So thank you so much for this and for everything that you've done for us this year. Thank you.
Okay, thank you both, Sumrit and Jennifer, for your presentation and for your work. I don't know if this is the first time this type of a survey has been done in any type of facility like this, but I would doubt that it's happened, especially with the numbers that are available to us. So the data is meaningful. I think even though we have still a ways to go with trying to get 100% participation in some of the data collection, but glad to see that we're working on it. At this time, I'll see if there are any public comments to the report presentation.
There is one hand up. I'll remind folks, this is item 6. If you'd like to make comment, please press *3. Again, *3. All right, caller, I've unmuted you. You've got 3 minutes.
This is Patrick Monette Shaw. I'm a gay man, and my hope is that when I develop dementia and need a skilled nursing facility in my old age, that I will have staff who will treat me with equity. But I find it really disturbing that given the CMS closure mandate, that the S2 predominantly LGBTQ plus residents are going to be facing out-of-county discharge where there may not be any equity or any flying fig of interest about SOGI data collection. This is preposterous that you're focusing on this when you really should be focusing on recertification efforts. In addition, given Commissioner Chow's lack of vision about what the loss of those 120 beds will mean to queer folk like me is appalling. Those future Laguna Honda residents who are hopefully by and large only San Franciscans will not have access in county to a facility that values and appreciates and gives equity concerns to folks like me. You know what? You guys need to focus on recertification for the next 5, 6, months between now and September 15th and maybe November, maybe January, before you earn recertification and can protect LGBTQ plus, I always forget the acronym, and people like me. So stop focusing on SOGI data collection. Focus on getting recertified. Thank you.
That is the only public comment that I see.
Thank you, caller. Thank you, Mark. Are there any comments or questions from members of the committee? Commissioner Green, I see your hand up.
Well, I just wanted to comment on this really thoughtful research, which was not only data collection, but also interpretation. I think, for someone fresh out of Berkeley, Of course, it was Berkeley. You've done a really wonderful job, and you know, I think this work will be so valuable going forward, and so many points that will inform future decision making. So I just wanted to compliment you on your contribution.
Thank you, Commissioner Green. I see Commissioner Bernal's hand up.
Yes, I just wanted to thank Sumrit and Jennifer for this research, particularly just coming off of Pride Month, and the perspective of the residents is a really good reminder that we need to celebrate our LGBTQ community and support them year-round. You know, we're very proud of Laguna Honda, particularly in terms of the HIV care it provides to its residents, and also very grateful to see the areas in which we need to improve, and very much appreciate your focus on data, which is critical to making any kind of institutional or cultural change. So just thank you again for the report, and I apologize, but I need to drop off from the meeting, but wanted to make sure I was able to stay for this.
Thank you, Commissioner Bernal. Any additional comments? I just wanted to say it appears from the data that even though that there are some trends, I think, in terms of what folks are experiencing and what they would like to see, what it does show to us is that, you know, that each person is still an individual, and we can't take for granted that, you know, even if there is a slight majority opinion from a qualitative as well as a quantitative survey, that we don't generalize, and that we do continue to take care to treat, as we strive to do always, to treat everybody as an individual, and to create those social spaces where that individual, those individual characteristics and personalities and such can come through. But thanks again for the work. I think I would like to see how we're able to incorporate this work into our recertification process and our overall work for the future. Thanks again. Okay, Mark,
Yeah.
do you want to call out
Thank you. The next item is consideration for a closed session. And we also always ask for public comment after the motion, so we'll do that today after we hear from you all.
Okay, can I have a motion to consider closed session?
So moved.
Second.
Okay.
All right. Folks on the public comment line, if you'd like to make comment about the closed session consideration, please press *3. I see one hand. All right, caller, you've got 3 minutes.
This is Patrick Manette-Shaw again. Thank you for bearing with me today, pointing out things that you people are apparently diminishing and downplaying and wandering off into closed session. I tend to believe that ever since last October, when you knew you were in trouble then with CMS, Grant Colfax, Mr. Phillips, DPH, have downplayed the severity of the problem facing, oh yeah, the Health Commission. And I believe you've held very few agendas addressing the loss of CMS certification, even though you've been discussing it in closed session for, what, 6, 8 months since October? You need to stop hiding from members of the public. After all, Laguna Honda Hospital is a citywide resource, not the personal plaything of the District 7 supervisor. You know, like Sean Ellsberg, or say Myrna Melgar, or Norman Yee. This is a citywide facility, and you are putting in San Franciscans in jeopardy of being discharged out of county, aggravating the number of skilled nursing facility beds available to all of us while you've been trying to cover your, what's it called? Cover your B word. It's got a couple of T's in it. By hiding and downplaying and diminishing the severity of what you're facing. Like I said earlier, shame, shame, shame on all of you. And oh, by the way, Commissioner Chow, after 30 years, you should resign from this commission to save face. Thank you.
Okay, commissioners.
Can you take a vote for the closed session?
Yes, I'm sorry. I'll do a roll call vote. Commissioner Guillermo?
Yes.
Commissioner Chow?
Yes.
Commissioner Green?
Yes.
I think that's everybody because Commissioner Bernal left. Okay, great. All right, so please give me 30 seconds to move us over, and members of the public, you will not see or hear what's happening, but we will come back if you want to wait in the open session. We are back in open session, commissioners, and if you would consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
We need a second?
Yeah, sorry. I second.
All right, roll call vote. Commissioner Guillermo?
Yes.
Commissioner Chow?
Yes.
And Commissioner Green.
Yes.
And now we are at a consideration for adjournment unless someone else has comments or questions.
Okay, I don't see any. Is there a motion to adjourn?
I would make a motion to
Second.
All right, I'll do a roll call vote. Commissioner Green?
Yes.
Commissioner Chow?
Yes.
And Commissioner Guillermo.
Yes.
Great, thank you.
Go all in and get a nice dinner and maybe a drink or two.
Take care, everyone.